All right, if you're gearing up for your PEBC exams, you know that cardiovascular pharmacology is a beast. And right in the middle of it, you've got this challenging topic, ventricular tachyarrhythmias. So in this explainer, we are going to break it all down piece by piece and give you that high-yield info you need to walk into that exam feeling totally prepared. So here's how we're going to tackle this. First, we'll lay the groundwork. What are VT and VF, and what are we trying to achieve? Then we'll dive into how they're diagnosed and why they matter. After that, we're going to spend some real quality time on a topic that is huge for us pharmacists, drug-induced QT prolongation. And finally, we'll wrap it all up by looking at how to manage these things, both in an emergency and for the long haul. Okay, let's jump right in. Before we can even think about treating these conditions, we've got to be crystal clear on what we're actually looking at on an ECG. First step, we've got ventricular tachycardia, or VT. Now, this definition is super precise, and you'll definitely want this one locked in your memory bank. What are we looking for? It's got to be 3 or more beats in a row, coming from the ventricles, and cranking along at over 100 beats per minute. That's the textbook definition right there. Now let's flip the coin and look at ventricular fibrillation, or VF. If VT is a fast, organized rhythm, VF is just, well, it's pure electrical chaos. On the ECG, you won't see any real QRS complexes. It's just this messy, quivering line. And clinically, that means the heart isn't pumping blood at all, which is exactly why this is a code blue situation that is always linked with cardiovascular collapse and is absolutely fatal without immediate help. So that naturally leads us to our goals of therapy. And you can really think about this on 2 different timelines. The first one is the right now goal. It's crisis mode. We have to stop the arrhythmia, get a rhythm that actually pumps blood, and stabilize the patient. Simple as that. But then there's the long game. The second goal is all about prevention, making absolutely sure this doesn't happen again. Okay, section 2. Let's dig into how we actually investigate these arrhythmias. See, it's not enough to just say, oh, that's VT. We have to play detective and figure out why it's happening, because that why is going to drive the entire long-term game plan. And that detective work always starts with a really careful history. Every one of these points is a massive clue. Did the patient pass out? That screams bad blood flow. Do they have a history of a heart attack? That points to scar tissue in the heart, which is a perfect spot for an arrhythmia to start. And you always have to ask about family history. Sudden death in a young relative, that's a huge red flag for a potential genetic cause. After we've got the story, we bring out the tools. The 12-lead ECG is our first snapshot. An echocardiogram lets us literally see the heart's structure and how well it's pumping. For those sneaky, intermittent arrhythmias, a patient might wear a Holter monitor. And for the really tough cases, we might even use a cardiac MRI to map out that scar tissue, or use special drugs to try and provoke a hidden syndrome. Now, this next point is a golden rule in cardiology, an absolute must-know for safety. Any wide, complex tachycardia, you have to treat it as VT until you can prove it's not. Why? Because the treatment for the main mimic, SVT, could be deadly if you give it to a VT patient. So especially in older folks, we play it safe. Assume the worst, and you'll keep your patient safe. It's also super important to distinguish between sustained and non-sustained VT. Think of it this way. Sustained VT, lasting 30 seconds or more, is a major medical event. It always needs a full workup and treatment. Non-sustained VT, on the other hand, is just a little burst. In a perfectly healthy heart, it might not mean much. But, and this is a big but, if that patient has a weak heart, like an ejection fraction under 35%, even those little short bursts are a huge warning sign. Okay, let's pivot to a topic that is right in our wheelhouse as pharmacists. This is where we really shine. We're talking about drug-induced QT prolongation. That QT interval on the ECG, it's our window into the heart's electrical reset process. And when drugs mess with it, they can set the stage for some really dangerous arrhythmias. You'll notice the QT interval isn't static. It changes with your heart rate. It gets shorter when you're running, longer when you're resting. So to compare apples to apples, we have to correct it for heart rate. The most common way you'll see this done is with the Bazette formula. This gives us the QTC, the corrected QT, and that's the number we use to make clinical calls. And here are the numbers you absolutely need to know. For men, we want to see a QTC under 470 milliseconds. For women, under 480. But the magic number, the one that should set off alarm bells in your head, is 500 milliseconds. Once you cross that 500 milliseconds threshold, the risk of a really nasty arrhythmia called torsades de pointes goes up a lot.
And it's never just about one thing. The risk of torsades is a big puzzle with lots of pieces. It's a combination of things. You've got patient factors like being female or older. You've got medical conditions like low potassium or heart failure. And then you have the drugs themselves. So you can see how an older woman with heart failure and low electrolytes who gets a QT prolonging drug is in a way, way higher risk category. It's all about the cumulative risk.
Now, this list is pure gold for your exams and for your day-to-day practice. And look closely. It's not just the classic heart drugs. We've got common antibiotics like macrolides, some antidepressants, antipsychotics, the list goes on. As the pharmacist, you are the last line of defense. You're the one who's going to catch these potential problems. So here's your mental checklist, your systematic approach. Before that prescription goes out the door, you check the drug's risk, you scan the patient's entire profile for other risks, and you ask, is there a safer alternative? If you have to use it, start low and go slow. And you absolutely have to counsel the patient. Tell them what to look out for and what to do if they get sick, like with a stomach bug that can mess up their electrolytes and crank up their risk.
All right, let's switch gears completely. We're moving into the emergency department. A patient rolls in, they're unstable, they're in a life-threatening rhythm. The clock is ticking, and what we do in the next few minutes is absolutely critical. The first line of attack is almost always electricity, but it's not one size fits all. If the patient is unstable but the VT is organized, what we call monomorphic, we use synchronized cardioversion. The machine cleverly times the shock to avoid making things worse. But if the rhythm is just chaos, like in polymorphic VT or full-on VF, there's nothing to synchronize with. So we hit him with a big, unsynchronized shock, defibrillation, to try and reset everything.
Now, what if the shocks don't work or the rhythm keeps coming back? That's when we reach for our IV drugs. Amiodarone is the heavy hitter, especially for really tough cases. And you've got to know that classic 300 milligram bolus dose. Procainamide is a great choice for a stable monomorphic VT. But here's the exception you need to remember. For torsades to points, the go-to drug isn't a typical antiarrhythmic. It's IV magnesium. Lock that one away.
Okay, so we've pulled the patient back from the brink. They're stable. Now what? The emergency's over, but our job isn't. The focus now shifts entirely to long-term management. How do we make sure this never, ever happens again?
This algorithm here is basically our roadmap for long-term therapy. Don't worry about memorizing every single box. Just focus on the main fork in the road right at the top. Was there a reversible cause, like an electrolyte problem or a drug? If yes, you fix that. If no, then pretty much every decision from here on out is driven by how well the patient's heart is pumping, their left ventricular ejection fraction. And that path almost always leads us to the gold standard of care for these patients. For anyone who survived a sustained VT-RVF that wasn't from a reversible cause, the best treatment we have is an implanted cardioverter defibrillator, or ICD. You can think of it like a paramedic, sitting inside the patient's chest, 24/7, ready to deliver a life-saving shock if that dangerous rhythm ever comes back. Big clinical trials proved it saves more lives than drugs alone. But drugs still have a huge part to play, usually alongside an ICD to cut down on how often it needs to fire. And the king of these drugs is amiodarone. It's so effective because it's so darn complex. It has a little bit of every antiarrhythmic class in it. But that complexity is a double-edged sword. It has a super long half-life, so you need loading doses, and it has some massive drug interactions. The two you have to know for your exam: when you start amiodarone, you almost always have to cut the patient's warfarin and digoxin doses in half. And because amiodarone sticks around in the body for so long, you have to be vigilant about its non-cardiac side effects. This is a huge counseling and monitoring point for pharmacists. The big ones to watch out for are the lungs. It can cause fibrosis, the liver, and the thyroid. It can send it either high or low. That's why any patient on long-term amiodarone needs regular blood work and checkups for these specific issues.
Okay, last drug we'll focus on is sotalol, and it's so important that you don't just lump this in with other beta blockers like metoprolol. It's not just a beta blocker. Yes, it has that property, but its real power as an antiarrhythmic comes from its class 3 action. It blocks potassium channels. That's what makes it good for VT, but it's also what gives it a significant risk of causing torsades to points, especially at higher doses. That's a risk your standard beta blockers just don't have. And that really brings us to the big final question that clinicians grapple with every day. We live in an age of incredible devices like the ICD. They are amazing at preventing death. But the shocks are no fun. So we use drugs to reduce the shocks and improve quality of life. But those drugs, they come with their own baggage, their own risks. And so the real art of modern arrhythmia management, and your challenge as a future pharmacist, is to constantly weigh that risk-benefit balance for every single patient, to help them not just live longer,
but truly live better.